Hello and welcome to the Echo by Web YouTube channel. It is a channel for professionals, mainly cardiologists and sonographers, but not only, dedicated to the world of echocardiography. The aim of this channel is to provide the basic physiopathology and methodology which are necessary to both understand and perform and interpret a complete echocardiographic examination. This channel will deal with many of the topics that we all have to engage with in daily practice. Valvulopathies, cardiomyopathies, systolic and diastolic function and dysfunction, and also the new technologies like left ventricular systolic strain analysis. My name is Paolo Barbier. I am broadcasting from Italy. I am a cardiologist with a special interest in imaging and echocardiography, and I will guide you through clinical cases and talks from my clinical experience addressing a wide range of echocardiography topics. My imaging, the images that you will see in my talks, are all based from my experience in Italy and in northeast China, where I have worked for about 5 years. Echo by Web is not only a YouTube channel, it is also a website, echobyweb.com, where you will find much of the materials I will present you in this channel. So let's have a look. This is the homepage of the website, echobyweb.com. Up here in about, you will find my credentials. Under Atlas, you will find 2 atlases of imaging, transthoracic and transesophageal. It's work in progress. Under Ecolab, you will find normal values for echocardiography, scores like the Wilkins scores, the Montgomery plaque classification, and analysis and quantification of the left ventricle, the mitral valve. And then you will also find formulas and calculations, guidelines, references, an example of a complete echocardiographic examination. You will also find here online calculators, which are Excel spreadsheets on the website with which you can interact, and you can make a lot of calculations, stroke volume through the valves, and you can find the indications for valve surgery based on the latest guidelines, European guidelines, and you can find also flowchart for the calculation of diastolic function from the latest recommendations. And this is the QR code with which you can access, for example, if you have a cell phone. The topic of this series of talks, which span over 5 videos, and this is video number 5, the last video, is the echocardiographic analysis of left ventricular systolic function in the real world. Now, this is of course a basic approach because the topic is very large, and these talks assume that you have a basic understanding of how to perform 2D and mode and pulse and continuum wave Doppler measurements. And however, you will find in the website that I just mentioned, echobyweb.com, a large quantity of educational material that can guide you through these topics. And this is the outline of this talk on left ventricular systolic function. We begin with an introduction and definitions, then we move on to physiopathologies and define the determinants of systolic function. We analyze the pressure volume loop as constructed invasively, and we see how invasively we define left ventricular contractility. When we move on to the aims and the qualitative evaluation of left ventricular systolic function, and then the mechanical function of the left ventricle through ejection fraction, and how to perform stroke volume assessment and cardiac output. And then we have the echocardiographic estimation of left ventricular contractility using isovolumic phase indices like the noninvasive dP on dt from mitral regurgitation and the Myocardial Performance Index or TAE index. And we end with the analysis of left ventricular longitudinal function using tissue Doppler because strain analysis will be the topic of a whole new another video. And these are how they are grouped in the 5 videos. This is video number 5, left ventricular contractility and longitudinal function, and now we will talk about non-invasive estimation of left ventricular contractility with the non-invasive dP on dt index and the Myocardial Performance Index. We have already discussed at the beginning of this talk about the left ventricular pressure volume loop here and how it is constructed by putting together the left ventricular volume curves with left ventricular pressure measurement. And down here, circled in red, we have the peak positive dP on dt, the first derivative of the pressure curve change during systole, during isovolumic contraction, and the rapid rise of ventricular pressure. This is widely used as an invasive measure of left ventricular contractility, although it is not the gold standard as we have seen. It is an estimate because it is still load dependent. And now let's see how we can non-invasively estimate this positive dP on dt. Left ventricular contractility can be estimated with some approximation, also with echocardiography non-invasively using isovolumic phase indices, specifically during isovolumic contraction phase that we have discussed in the section of this talk about physiopathology. The calculation that you see here is a classic. It was published in 1989 by an Italian group and correlates directly with invasive positive systolic dP on dt. The calculation shown here cannot be performed in every patient because it requires a continuous wave Doppler flow profile of mitral regurgitation, as we see here in panel A. This is at least moderate regurgitation, so it may be difficult with mild and certainly cannot be done with grade 1 trace mitral regurgitation. And it requires a well-defined spectral profile during the isovolumic phase, during the ascending part of the spectrum, like in here and in here, as in B and C. We need to identify on the velocity time integral curve 2 points, as shown in panel D, this schematic drawing. The first point is at the 1 meters per second velocity point here, A, which corresponds to a pressure gradient of 4 millimeters of mercury between the left ventricle and the left atrium during according to the simplified Bernoulli equation during isovolumic contraction. The second point is at 3 meters per second point, which corresponds to the pressure gradient within the atrium and the ventricle of 36 millimeters of mercury, still according to the simplified Bernoulli equation. The difference between these two pressure gradient points, the 1 meter and the 3 meters per second, is 36 minus 4 millimeters of mercury. It's a 32 millimeters of mercury difference, as shown here in panel D. Once identified these 2 points, and here on this normal subject with a steep rise of the velocity time integral, it's this point here, 1 meter per second, and this point here at 3 meters per second. In this dilated cardiomyopathy patient, they are farther apart. This is the point at 1 meter per second, and this is the point at 3 meters per second. So once identified these 2 points, we need to measure the time difference on the x-axis here. We need to measure the time difference between the 2 points. So it will be the interval t shown here in panel D. What we want here is to calculate the rate of pressure rise, which corresponds to the invasive positive dP on dt. And the calculation is done by dividing this difference in pressure gradient, so the 32 millimeters of mercury, which is a fixed gradient between the 1 and 3 velocity points, by the time which is being measured in our patient. A normal value will be equivalent to or greater than 1200 millimeters of mercury per second. And in panel B and C, you see respectively a normal patient and a patient with dilated cardiomyopathy, both with detectable mitral regurgitation. So the time difference t between these 2 points in a normal patient is 15 milliseconds, and that takes us to a calculated RPR, or positive dP on dt, of 2100 of more than 2100 millimeters of mercury per second. So perfectly normal. Whereas in the patient with dilated cardiomyopathy, we have the time difference of 56 milliseconds, which takes us to the calculation of an RPR or positive dP on dt of 571 millimeters of mercury per second, which is clearly abnormal. So this calculation shows us a normal contractility, an estimated contractility, and this other calculation, this patient shows us a clearly reduced contractility of the left ventricular myocardium. And this is an example of the measurement of the RPR that we have just seen, the methodology, in a patient with a dysfunctional aortic valve prosthesis, severely reduced left ventricular systolic function, and increased filling pressures, the 79-year-old patient. You see here the mitral regurgitation in a 3-chamber view. It's a mitral regurgitation, but still we can obtain a nice velocity time integral profile of the mitral regurgitation, so we can easily pinpoint the 1 meters per second velocity point and the 3 meters per second velocity point, and easily measure the t time, the interval between the two velocity points, which is 118 milliseconds, which gives us an RPR or positive dP on dt or contractility of 271 millimeters of mercury per second, which is a greatly decreased contractility of left ventricular myocardium. This can also be qualitatively assessed because you can clearly see the dagger-shaped profile of the mitral regurgitation. You have this very slow increase in velocity, and the other thing that you should note is the 4 meters per second maximum velocities, which is quite low, and it's secondary to reduce contractility of the left ventricle. The other isovolumic phase, isovolumic contraction phase, but not only index, is the Myocardial Performance Index, or TEI index, from the name of its first author. It was published in the 1995. Now, this is a dimensionless index of global left ventricular function. So it doesn't consider only isovolumic contraction, it measures also isovolumic relaxation and ejection phase. So because it considers both isovolumic contraction and relaxation, it is a global index which includes contractility, isovolumic contraction, and relaxation, isovolumic relaxation. So it is not really a measure of contractility per se, but we mention it, I mention it here. So as shown here on the right, the MPI is calculated as the sum of the duration of isovolumic contraction and the duration of isovolumic relaxation, isovolumic contraction and isovolumic relaxation, and it's divided by the left ventricular ejection time here. This dimensionless index increases with the increasing dysfunction of the left ventricle and decreases when the function gets better. And this is because with increasing dysfunction, so with decreasing contractility and decreasing relaxation, the isovolumic time increase in duration, whereas ejection time of the left ventricle decreases. And this, of course, increases the ratio. Whereas when the function gets better, you will have an increase in ejection time and a decrease in one or both of the isovolumic indices, so the ratio will decrease. So, of course, because it includes both isovolumic contraction and relaxation, the index may change because contraction changes or because relaxation is modified, or both. So we cannot, so only when we do the calculation we see if it's more a problem of isovolumic of contraction or of relaxation. But the index by itself indicates global function. And of course, we must consider, like everything else in non-invasive echocardiography, that this is an estimate, of course. The index can be calculated, so the time intervals can be calculated using either M-mode echocardiography or pulse Doppler of the LV outflow and mitral inflow. And so this requires great attention, that because these are separate recordings at the two levels, the heart rate must be exactly the same. Or the index can be calculated, but the measure will be different, the timings will be different, the numbers will be different, using pulse tissue Doppler of the mitral annulus. In this case, you only have one recording, because on the same recording you have both the outflow and the inflow timings. One way of doing the measurements, but not the only one, is to calculate what is called A here, so the time interval between the end of mitral flow here and the beginning of flow on the next cycle. So you have this total time A, and then you measure ejection time, and by subtracting A, which includes both isovolumic period and ejection time, if you subtract the ejection time B from A, you will obtain the sum of isovolumic contraction and relaxation. So you will take this result at the numerator here and divide by B, and this will give you the MPI. And this is one way of doing it rather quickly. The calculation can also be done using the EKG in substitution for the time intervals, and I strongly suggest not to use this method here because I think it's quite inaccurate. And these are the normal values for my former Echo lab. These are the demographics of the population that used for normal values. And we have the mean and standard deviation and 5 to 95% confidence intervals. This is the heart rate, and we have the isovolumic contraction time, isovolumic relaxation time, ejection time, and calculated MPI. And you see these are the means. Typically, isovolumic relaxation time is longer than isovolumic contraction time in normal subjects. This is the ejection time mean, and this is the mean value of MPI. It's easy to remember, it's around 0.5, and the 5 to 95 confidence intervals are from 0.32 to 0.69. Now these are normal values for the pulse Doppler evaluation. The tissue Doppler evaluation has different values, which I don't have here now, but you can find it in the literature. And here we have two calculation examples in two patients. The patient up here, A, B, and C, is a patient with a biological aortic valve prosthesis. It's an Ozaki procedure. It's a construction of the aortic valve from pericardium, and normal MPI. The A, B, and C. A is with pulse, transmitral, and LVOT, and B and C is done with tissue Doppler. The patient in D, E, and F is a patient with dilated cardiomyopathy, which has an increased MPI. And again, mitral and LV outflow here on the left, and on the right, tissue Doppler. So you see that with the modality of pulse Doppler, the A value, so the sum of the ejection plus the two isovolumic periods, is measured between the end of the A wave of the previous cycle and the beginning of mitral filling, so the beginning of the E wave of the next cycle. And then ejection is measured, or the parameter B is measured directly on the pulse Doppler of the velocity time integral of outflow. And here you have A is 470, B is 337, and the calculation that we have seen before takes us to an MPI of 0.43, which is totally normal. And down here in D, the patient with dilated cardiomyopathy, you can see a very severe reduction of function of 17%. We have the parameter A, which is 394 milliseconds, and ejection is 218, much less than the normal patient, the patient up here with normal contractility. And this takes us to an MPI of 0.81. As we have seen, it's definitely a decreased decreased myocardial global function. It's well above the upper limit 95% confidence interval of 69. So up here, global, normal, functional ventricle. Down here, reduction, global reduction of ventricular function. On the right panel, sorry, here we have tissue Doppler. As you can see, you have a single tracing, and we do the mean of the septal and the lateral annulus, of course. And with tissue Doppler, you go and measure directly the isovolumic intervals. Okay, so we have the isovolumic relaxation here before the mitral period, the diastolic period, and the isovolumic contraction here before the systolic period. We measure them directly, and also we measure ejection, and the calculation takes us to 0.41 on the septal side and 0.46 on the lateral side. In this case, the values done with the two methods are quite similar. Down here we have the same methodology for the patients with reduced contractility and prolonged relaxation, the patient with dilated cardiomyopathy, and you can see that we have an increased isovolumic relaxation contraction time and an increased isovolumic relaxation time, which takes us to an MPI of septal of 1.1 and lateral of 1.02. So it is greatly prolonged, and notice that in this patient which has an abnormal global function, the numbers are quite different. So we don't have the same number, which means that if you measure this, and this parameter is quite useful for a follow-up of the patient in therapy, for example, or during adverse or remodeling. And to do this, we must use the same method, so either pulse Doppler or tissue Doppler. And finally, the last consideration, last thing you should note is that by measuring directly of having the numbers of the isovolumic contraction and isovolumic relaxation, we can say in this patient which has a global dysfunction that the global dysfunction, the prolonged MBI, is due to secondary to both a prolonged ICT and a prolonged IRT, but much more prolonged ICT compared to normal values than relaxation. So contractility would be more dysfunctional than relaxation. As we have said, the isovolumic indices estimate contractility or global function of the myocardium, but are not the gold standard because they're still load dependent. Let me show you an example of this in these two patients which underwent CRT, cardiac resynchronization therapy, pacemaker optimization procedure, and are followed up with echocardiography to do the optimization procedure. The CRT pacemaker optimization procedure shown here aims to modify sequentially the atrioventricular delay, the blue here, atrioventricular delay, these are the steps, and these are the values of the delay, and the interventricular delay, the green line here, again these are the steps and these are the values of the delays, to find during this stepwise sequence, an optimal combination of AV and VV delays, which means a combination that maximizes stroke volume and diastolic function, the filling of the left ventricle. So the first patient in panels on the left, A and B, is a 77-year-old patient with dilated cardiomyopathy, previous mitral valve repair, and has a Medtronic biventricular pacemaker, and this is a step at 12-month follow-up after the pacemaker implantation. In the lower panel here, we see the optimization protocol with the changes in the atrioventricular delay and subsequently the change in the interventricular delay in green. So first we change the AV and then we change the VV. In the upper panel in A, we see the echocardiographic measurements performed at each step. And so we have here from top to bottom, the yellow line is the RVRT. And then the light blue and the dark blue lines are the MPI, the Myocardial Performance Index. The lines are different because there is a slight difference in how the measurements are made. And then the red line is the Isovolumic contraction time. The same method is used for this other patient in panel C and D. This is a 79-year-old, an ischemic dilated cardiomyopathy, a St. Jude biventricular ICD pacemaker, and this optimization is performed at 15 days after implantation. Now, I won't describe the whole protocol for the two patients, so the optimization procedure. What I want to stress here and let you note is the preload dependence of the MPI. Because when we change the AV interval, we change the preload of the ventricle, and as you see, it changes the MPI, both here in this patient and in this other patient. And this demonstrates, even in this non-invasive procedure, that the MPI is preload dependent, so it's not really a gold standard of global ventricular function. The load must always be taken into account. Now let's move on to the last section of our talk, that on left ventricular longitudinal function and how to assess it. We will not talk about deformation or strain imaging, which will be addressed in a forthcoming talk on this channel. We have already seen this table at the beginning of our talk on systolic function. Let's recall that the global left ventricular function is the product of different myocardial shortening vectors, the radial one, the circumferential one, and the longitudinal one. And ejection fraction measures global function because it is the result of all these vectors taken together. The analysis of systolic function, of ventricular systolic function with M-mode, the MAPSE, or measuring with 2D the systolic descent of the mitral annulus, or the analysis with pulse tissue Doppler of the mitral annulus, or deformation or strain imaging, measures by definition only the longitudinal vector. So it must be clear that the analysis of longitudinal function is not a surrogate for the global ventricular function. So tissue Doppler or strain analysis is not a substitute of ejection fraction. These parameters are complementary in the analysis of left ventricular systolic function. The complementary analysis of longitudinal function has its own rationale, which lies primarily in the fact that longitudinal function, because it looks mainly at subendocardial fibers, is impaired genetically before the circumferential and the radial function. So an analysis of longitudinal functions sees systolic impairment of the left ventricle before you can see it when analyzing global function with ejection fraction. So longitudinal function is reduced before global function. So a primary field, a clinical field of the application of the analysis of longitudinal function is currently cardio-oncology, when looking at the negative inotropic effects of certain therapies like anthracycline. However, the use of longitudinal function is expanding in the realm of the remodeling of the left ventricle in valvular heart disease, in cardiomyopathies, because of its dual ability to identify an early reduction in systolic function, and also, as has been seen in this last year, because of its ability to define better patient's prognosis than ejection fraction. This figure shows how the systolic dimension decrease from diastole to systole, dimension decrease that we measure as ejection fraction as a global index, is a product of radial shortening, the red arrows here, and longitudinal shortening, the orange arrow here. Longitudinal shortening is caused by the shortening of the longitudinal fibers of the ventricle that originate from the cardiac base, here the mitral annulus in the left heart, the dotted orange line, which is part of the fiber skeleton of the heart. The longitudinal fibers, this orange dashed line here, are inserted on the mitral annulus. They go along, especially the subendocardial border. They reach the apex, which is fixed on the diaphragm, and loop back to the cardiac base through the papillary muscle and the mitral chorda apparatus. In systole, the cardiac base, on the left heart it's the mitral annulus, is pulled in systole towards the apex by the shortening of the longitudinal fibers. This is why we say that there is a systolic descent of the cardiac base, intending descent towards the cardiac apex. Since the posterior superior wall of the left atrium, you see the superior one here drawn in red, is fixed to the pulmonary veins and the spinal cord, and we have seen this in the previous slides. During systole, because the base of the left atrium, which is the mitral annulus, shifts down, descends toward the apex, this brings to an expansion of the left atrium during its diastolic filling, during the atrial reservoir phase, also because of this systolic descent. And because of this yellow line here, drawn between the superior wall of left atrium and the left ventricular apex, does not change between diastole and systole. So the overall outside border shape of the left heart, but also on the right side, does not change. What changes is this reciprocal change in volume of the left atrium and the left ventricle. And this change in volume corresponds to stroke volume. Now, interestingly, this figure here, the white drawing, the colors, I have added the colors, but the white drawing comes from this publication here, 1981, Clinical Cardiology, that I have used in university when I studied medicine. The white lines here. You see that during systole, the author showed that the left atrium in systole shifted down without changing dimension towards the apex of the left ventricle together with the mitral annulus. So the atrial expansion during ventricular systole to the left atrial reservoir phase was completely omitted. So strangely, although the fact that the ventricle also had a longitudinal contraction was known, and the longitudinal contraction of the heart was known since Leonardo da Vinci, so that makes a lot of time, somehow the atrial physiology here in the 80s was kind of overlooked. The analysis of the systolic descent of the cardiac base was the first measurement performed in echocardiography historically. As you can see from this image on the left, it is the ultrasound detection of the motion of the mitral annulus that you see here, with a yellow arrow, published as early as 1967 by the group of Feigenbaum. You can see the end diastolic position of the mitral fibrous annulus in end diastole, and then the movement towards a transducer which was placed at the apex towards end systole here. This is what was later defined with M mode, because this is before M mode, it's an A mode, as MAPSE, the mitral annular plane systolic excursion. The equivalent, better known today on the right side for the tricuspid annulus, is the TAPSE. The fibrous mitral annulus is the most reflective part of the cardiac base and in generally of the heart. So the structure was most easily captured by this single ultrasound beam of the first ultrasound experiments. But the same kind of measurement, the displacement of the mitral annulus or descent of the cardiac base, can also be seen or measured by analyzing the displacement of the mitral annulus as drawn by the software when you do the planimetry or the forward and two-chamber views. In some softwares, the planimetry, the diastolic planimetry and the systolic planimetries are superimposed, and so you can see how the base of how the mitral annulus, or the base of the heart, is displaced in systole towards the apex, as we said, which is fixed on the diaphragm. And here we can see nicely in a normal subject consistent displacement of more than 1 centimeter in systole, in the 4-chamber view and in the 2-chamber view. So both the M mode and the 2D mode analysis of the mitral annulus in systole analyze, as a matter of fact, the extent of this movement, whereas with tissue Doppler, we will see in a minute, analyzes the velocity with which this movement occurs during systole. Now let's look at the methodology for pulsed tissue Doppler imaging that we see here on this slide. With this technology, what we have to do is to place the sample volume when we enter in the color Doppler, color tissue Doppler mode first. We put then the pulse sample volume at the base of the lateral wall, the mitral annulus just below the lateral wall, and then on the mitral annulus at the base of the inferior interventricular septum. And these are the spectral tracing down here from the lateral position and the septal position. This is an example of a good quality tissue Doppler of the mitral annulus. Note the velocity spectrum. Note the profile with a very narrow, well-defined velocity band along all the cardiac cycle in systole and in diastole here. Notice how the beginning of diastole, in fact the beginning and the end of each wave is very well demarcated and free of artifacts or smears. The different waves are very well recognized. So we start with a wave which can be very small or larger depending on the conditions of the myocardium. Usually this is a normal exam, so the isovolumic waves are small. In pathologic conditions, the isovolumic waves may be much larger. So we have an isovolumic contraction wave here. We are on the septal side. Then we have 2 systolic peaks. So when you have a good quality tissue Doppler tracing, you usually see 2 peaks in systole. We don't know exactly why there are 2 peaks or their exact significance. There's still ongoing research on this, but there are usually 2 peaks, and what you do is that you measure the prevalent one, be it early or the late systolic ones. Then we have, not always, but often we have, like we see on the lateral side here, an isovolumic relaxation peak, and then we have the early diastolic ventricular relaxation peak, and then we have the late diastolic atrial contraction peak. And the name are S primes for the systolic, E prime for the early diastolic, and A prime for the late diastolic peaks, septal and lateral. Usually what we do is to measure both and then average the values before using them in our report. Now it must be made clear that when we use this methodology, because we measure the annular velocities only at 2 locations, septal and lateral, and thus we omit the anteroseptal, the inferior, the posterior, and the anterior, we make an approximation of the global longitudinal function. We only measure 2 locations. So we are not measuring velocities which are relative to the anterior interventricular septum, the anterior wall, the posterior and the inferior walls. Originally, in the first tracings, they were all considered, but then in the guidelines it was decided to place only these 2 to make things simpler. Otherwise, probably the technique would never have been adopted in the clinical setting. So these limitations must be kept in mind if the patient, for example, had ischemic heart disease or segmental wall motion abnormalities, or if there is segmental hypertrophy, because both ischemia, chronic and acute, and hypertrophy of the walls, they all reduce systolic function even when, as we said, ejection fraction is still normal. And here are the normal values for pulse tissue Doppler, systolic and diastolic peak velocities. On the left here from the literature, here you see the references, and on the right from my former Italian echo lab, systolic, early diastolic, and late diastolic. Please note that although the systolic here from the literature and here from this local normal population of the lab is practically identical, and also the A wave, note that there is a significant difference from E prime. From the literature here, the genetic population and the local population where you work. So again, I strongly suggest to have an idea of your normal values from your local population, not only for research, but as shown here for clinical purposes. Now, I would like to present you a graph which relates the tissue Doppler systolic wave on the vertical axis and biplane ejection fraction on the horizontal axis. And I present you this because I think this relation pinpoints the rationale for the clinical use of tissue Doppler imaging for the evaluation of longitudinal function. Many people are not using tissue Doppler today and they don't have strain, so this is to let understand how it could be useful. So on this Cartesian plane, we have the tissue Doppler's systolic wave, as we said, the lateral one, but we have both peak. The first early systolic and the late diastolic and the late systolic peak, which in this general population here don't seem to change much. Now, if we divide the graph in 4 quadrants based on the cutoff values of 45% ejection fraction, but if we use 50, the results don't change, and based on 8 or 6 centimeters per second as a cutoff for the lateral systolic tissue Doppler wave. So we obtain these 4 quadrants. Let's start with quadrant A. And here are all the patients, because these are both normal and patients with heart disease mixed. So in this higher left, right upper quadrant, we have patients with a normal ejection fraction and a normal tissue Doppler longitudinal function. In contrast, in the quadrant B, the lower left one, we have patients which have both reduction of global biplane ejection fraction and reduction of longitudinal function. But the most interesting quadrant is C, because here we have the patients which have a normal ejection fraction, so a normal global systolic function, and a reduced longitudinal tissue Doppler function. So, and these are the patients where we detect an abnormal myocardial function, although our standard clinical ejection fraction is still normal, so hypertrophy or chemotherapy, valvular heart disease, initial cardiomyopathies. These are all the patients with an initial reduction of systolic function. And this is very important because we know that across most of heart diseases, systolic function begins to decline first along the longitudinal vector and only after along the radial and circumferential vectors. I am making this simple, but it can stand for most diseases. So we can detect these patients only using an analysis of longitudinal function. And tissue Doppler, although qualitatively speaking is much less powerful than the strain analysis, is still useful in the clinical setting for this purpose. And finally, you may ask yourself, what about the upper left quadrant D? Well, here we don't find patients. There are no patients, because when you don't find patients which have a reduced global function and a normal longitudinal function. By the time that the global function is reduced, longitudinal function is always reduced, has gone down, declined much earlier. So there should be no patient here. And if you find patients here, it probably means that you either made an error in calculating ejection fraction, or something went wrong when you measured longitudinal function. So this is why it's important to use in a clinical setting you study a longitudinal function. And in this slide we have a couple of examples of the use of the tissue Doppler analysis of the mitral annulus in a patient with aortic stenosis and normal ejection fraction, the upper panels, septal TDI here and lateral tissue Doppler on the right, and in a patient with dilated cardiomyopathy, moderate reduction in ejection fraction, and mild increase left ventricular filling pressures. Again, the quality of tissue Doppler is good. You can see very well all the waves, a narrow band of velocities, so we know already that the analysis will be accurate. And in the patient with aortic stenosis, we see that at the septal annulus level, the systolic wave is around 4 centimeters per second, so it's clearly reduced. Whereas on the lateral side, the velocity is around 6 centimeters per second, so the average is around 5, and it's clearly reduced. Note that here we are measuring the second systolic wave, the higher peak. Since we have reduced longitudinal function due to hypertrophy and increased afterload of the left ventricle, remember that left ventricular afterload can influence longitudinal function. We are referring to the previous graph. We are in the lower right quadrant, the C quadrant, where ejection fraction is normal and longitudinal function is initially reduced. In the patient with dilated cardiomyopathy, there is further reduction, 3 centimeters per second on the septal side and 5 on the lateral side, a mean of 4, so clearly markedly reduced alongside with the moderate reduction of ejection fraction. So here we are on the B quadrant of the previous graph with a reduction of both global and longitudinal vectors. And this is another example of another patient with a follow-up in dilated cardiomyopathy. At baseline of this patient, we have a severe left ventricular dilatation. We have an absolute value for the end diastolic volume of 220 milliliters. We have a severe reduction of ejection fraction, 26, an estimation of increased left atrial pressure, the E on E prime is 24. We have a moderate dilatation, mild to moderate dilatation of left atrium, and normal pulmonary systolic pressure. There is diffuse hypokinesis, and the patient is a 55-year-old male. Look at tissue Doppler imaging, and we have a peak systolic velocity of almost 3 centimeters per second, so marked reduction of longitudinal function. After 2 years of follow-up, the same patient is examined again here, and so now he is 57 years old, and we have a normalization of end diastolic volume from 220 to 77 milliliters, and we have a normalization of ejection fraction from 26 to 62, and of filling pressures. E on E prime falls from 24 to 10. Left atrium is still mildly dilated, and pulmonary pressures were normal and are still normal. Now look at the tissue Doppler. We see that it has increased from the value of 3 to a value of 7, so it has more than doubled, but it is still reduced. Note that here the quality of the tracing is much better than this one because the machine here has changed. This is a newer echocardiographic equipment that has been used. So despite this apparent recovery of myocardial function and remodeling, favorable remodeling, longitudinal function tells us that the recovery is not complete. So this is why the latest European heart failure guidelines are referring to this recommendation, and they suggest to use the term remission, not recovery, because if you go and look at in depth, in fact, you may find that the ventricle is not completely normal. We still have a subclinical, as we say, reduction of function that we see along the longitudinal axis. And this recommendation was written to support the concept of ongoing therapy in these patients, although ejection fraction was normalized. As we have said, the pulse tissue Doppler technique has obvious limitations. It is a segmental analysis which not only looks at only two ventricular walls, the inferior septum and the lateral wall, omitting all the others in this bullseye view, but it also prioritizes the basal segments of all the ventricular walls and more than the apex. In this slide, you see an example of patient with a prevalent mid to apical alteration of wall motion as evidenced by this 3D multi-slice exam. So we have the mitral valve level here and the apex here. And you can see the wall motion is abnormal starting at this level up to the apex and in panel A. Note how in panel B the tissue Doppler, pulse tissue Doppler examination shows a normal systolic peak of around 9 to 10 centimeters per second in this patient. And look at panel C, look at the biplane ejection fraction, it is 49%. As I said 2 slides ahead, and there should be no patients in our graph plotting tissue Doppler versus ejection fraction. There should be no patient with a reduced ejection fraction and normal tissue Doppler, and this is a classical example of a pitfall. So technically the tissue Doppler was measured correctly, but tissue Doppler, since it prioritizes the function of the base to mid of the ventricle, or this segments here, it does not really reflect, I cannot really read if there is a segmental problem mid to apex as in this patient. In contrast, and this is a systolic strain analysis, we see that this kind of analysis, even at the global level, the GLS, the global longitudinal strain, is reduced. It's -13, which is a moderate reduction, since the normal value, the average value with this kind of software, which is the GE EchoPac, is the mean average is 20, -20, and the lower limit of normal is around -18. And you can see that the segmental analysis provided by strain imaging shows correctly the normal values at the base and the abnormal values here from mid to apex, which reflect what we see here on wall motion analysis. So what is really very interesting today with the systolic wall deformation analysis, the strain technique, is that we not only have a global value, which is quite easy to obtain with this software, but also we have the segmental analysis. For the first time, we have an accurate segmental analysis in echocardiography. This type of imaging is now a standard across different proprietary software such as the GE, the Philips, Toshiba, and now many others. Here on the bullseye, the darker red points to normal values. You can see here -19, -18, -19, they're all normal values. -17, 16, and 15 are mild reduction, and then -12 is a moderate, and -9 we're going towards a severe reduction of longitudinal function. But this corresponds, you can see, to almost or a severe hypokinesis of the apex. The focus of the present-day guidelines and recommendation concerning the analysis of longitudinal ventricular function in echocardiography is on deformation of strain imaging. However, not all echocardiographic equipment, especially the older ones, has strain imaging on board, whereas tissue Doppler technology today is ubiquitous. So let's see what are the clinical applications today of systolic tissue Doppler imaging. And they are basically the differentiation of physiologic from pathologic hypertrophy in the athlete's heart, and or in young subjects which undergo training. And we have the early detection of myocardial dysfunction in cardio-oncology, but also in valvular heart disease and in cardiomyopathy. I believe that systolic tissue Doppler should be part of a routine examination when you are working in quality with echocardiography. And this is the end of the talk about echocardiographic analysis of left ventricular systolic function and dysfunction. The talk spanned 5 videos. This is the last one. You are on the Echocardiography channel, where you can find this talk, and presently are available 2 other talks. One is the echocardiographic analysis of left ventricular diastolic function and dysfunction, and the other one is about the echocardiographic analysis of volumes and mass. I remind you the echobyweb.com website, which is a companion to this echocardiography channel, where you will find a lot of material for echocardiographers and cardiologists, and see you on the next video.